Hi, everyone. I hope you can hear me, and welcome to the medical providers update call for this week. I'm Ray Vohra. I'm the interim health officer for Fresno County Public Health Department, and I will go ahead and get started. I'm going to share my screen here. Hopefully, you can see that. Um, Okay, so we'll go through numbers. We'll talk a little bit more about vaccines. We'll talk a little bit about this concept of crisis care standards and surge protocols, which our hospitals and emergency departments are definitely brushing off during this very challenging time. And then we'll have some updates about monoclonal antibodies and oxygen protocols. All right, sorry, I'm having a moment here. So in terms of cases, this is just a very, very grim time. We're logging just a record number of cases per day. We're up to 59,640, which is shocking even to me, knowing that we're in the middle of this surge. Unfortunately, the number of deaths are also climbing very, very quickly. December is already the deadliest month that we've had in this pandemic. And we've yet to log all of the December deaths. So these are just very unfortunate realities that I know all of my hospital colleagues are contending with, and I'm sure you in all of your practices are hearing stories and seeing patients that are suffering and succumbing to the coronavirus. In terms of our case metrics and things like that, it's become less important. We're hoping we will get out of this surge, and then we will go back into this blueprint, which looks at things like cases per day. The case rate is actually 58. And if you'll recall, we're trying to get to, we'd be happy to have 4 to 7 cases per 100,000. So we're up at 58. So we're way above even the bluest tier. The most purple tier. Overall testing positivity is also very high at 16%. Again, being above 8% puts us in the purple tier. The state is also looking at ICU capacity, and ICU capacity isn't included in the blueprint metrics, but it's something else that they started to look at, especially when the surge started happening. As a region, our ICU capacity is 0. That should surprise no one who is working in the ICUs and in the emergency departments. But they are tracking that. If the ICU capacity ever comes up above 15%, then the regional stay-home order would be lifted for our region in the Central Valley. Doesn't look like it's going to happen anytime soon. Okay, this is from last week, but also worth mentioning this week that we have a document posted on the CDPH website, which basically allows healthcare workers to come back before their 14 days of quarantine are up. They can come back on day 7 with testing, if the testing is done on day 5 or afterwards, and they can come back on day 10 if they remain asymptomatic. So hopefully you're taking advantage of that if you need to, if you're experiencing crisis care staffing or a crisis level of staffing. The next, I think, layer that we could invoke is to bring back people who are actually COVID positive. And that's where, it would be a very cautious step to take, and something that the hospitals would definitely have to dialogue amongst themselves. But even out in ambulatory practices, this is something that you may want to know about. If you're just having to bring back COVID positive individuals, please work with us, get advice from us about how you could make that happen. But the assumption would be that COVID positive individuals could come back and do healthcare services for COVID positive patients. It really is a signal that we are in very dire straits whenever we have to use COVID positive staff. Obviously, they would have to feel well, they would have to be asymptomatic or minimally symptomatic, and we would have to take all precautions possible to make sure that they don't infect non-COVID individuals, whether those are coworkers or patients. And so it's not to be done lightly, but there is language and there is this concept that it's possible to do. And other states are going there. So we wouldn't be the first state to, or the first region to take that step. Let's talk a little bit about vaccines. So this is the Pfizer product in our ultra low temperature freezer. Each one of these little pizza boxes has 975 doses. Our vaccination partnership with the hospitals is definitely bearing fruit. It's going smoothly, and our hospital partners have risen to the occasion and started to vaccinate the frontline staff and their healthcare providers. So kudos to you for just leaning so hard into this process very quickly. This requires quite a lot of prep work in terms of getting registered for various databases, making sure that the patient-facing materials are appropriate, and making sure that the appointments are done safely, et cetera. So I know that this had to be done just in the matter of days, and all the hospitals did a really great job getting this started, at least. I mean, obviously, kinks are still being worked out, and we're continuing to support. So we're definitely not through it, but this is one of the better, I think, stories that came out of this year, is the fact that we do have vaccines available and they're being used for our healthcare providers. And please continue to tell stories about that. I think the more that we normalize getting a vaccine, the better off we will be in helping to convert people who are vaccine hesitant, vaccine skeptics, into just seeing that, if all of our medical leaders and area community doctors and healthcare staff are getting a vaccine and really announcing to the world that they've gotten their vaccine, I think that does help people feel more comfortable with the concept of a relatively new vaccine that might help prevent a very scary disease. So in terms of allocation recommendations, this is a slide from last time. The state is fleshing out more and more plans, but this is the general framework of where they are putting people, which is that tier 1 is broken up. Phase one is broken up into different tiers, all of which are kind of frontline patient-facing occupations, and include acute care hospital staff, skilled nursing facility staff, EMS and EMT providers, and dialysis center staff. With tier 2 and 3, they basically are now providing vaccines to intermediate care facilities, home health care, and in-home support services. We've heard from hospice care providers because they're certainly frontline on that front, and I would say that I would think of them as part of the tier 2 workforce, as well as community health workers, field staff from public health, and primary health care clinics would also all be considered tier 2. Tier 3 would round out the specialty clinics, dental clinics, and laboratories where patients come to get those services. And really, we have the same impatience that many of you do. We're getting a lot of emails from you. We're trying to give you good information. I'm going to share a website that we're creating, which will go live hopefully by later today or tomorrow, definitely by this weekend, which will give you the information that you need to know if you're interested in being a vaccine provider. If you just want to get vaccines for yourself and you fall into one of these tiers, then this will be good information for you also. But especially for those clinics that are ready to become vaccine providers, we want to create basically a landing page and a welcome packet just to get you up to speed about what you need to do in terms of the applications to become a vaccine provider. Before I get to that, just remember that there's other kind of parallel streams. So you may want to check into whether you qualify for one of these other parallel streams. Like, for example, if you're working within the correctional system, the Federal Bureau of Prisons has these other vaccine planning strategies. The Department of Defense is providing vaccines for active duty and retirees. Um, the VA is providing vaccines to the veterans facilities. The state veterans homes, we do have some here in the county, and we're going to be helping them. So that's why this section is highlighted. But check with the VA to see if that might be a way for you or your staff. If you're considered a VA staff member with one of your affiliations, then you may be able to get vaccine that way. And also the Indian Health Service. I know this won't cover a lot of people, but it is interesting that these are parallel streams of vaccine distribution that public health is not actively involved in. And so just for your own information and for completeness, I just wanted to include this slide. All right, so the Vaccinate All 58 campaign, it really means vaccinate all 58 counties, not that we need to vaccinate 58% of people to get to herd immunity. It wasn't my slogan. It's something that the state came up with, but basically that's what the state is pushing out as the message, is to vaccinate all 58 counties. And this is basically information for medical providers. So if you go to this site, it will basically show you what we've constructed so far. And just by way of disclaimer, this site is not yet live. So it may undergo changes this weekend. And so just keep that in mind. Hopefully not a lot of changes. And the next slide shows you what we have on there so far. So it's basically, a welcome page. There's actually a vaccine page for the public, which I will show you in the next slide. And then, like, what are the required trainings that you need to have under your belt in order to become a vaccine provider? The vaccine provider required trainings by CDPH, and then some of the site requirements are fleshed out here. We're actually going to have a team of people to help orient you, to help get you up to speed. So there are going to be human beings here in the county that will work with you. The enrollment process will be something called COVID Ready, and I'll show you what that looks like as well. But COVID Ready is the site that allows you to get registered. You have to do an application, share what kind of site you have. If you want to store vaccine, you kind of have to prove that you have a cold chain established to store vaccine. If you're not able to store vaccine at ultra low temperatures, that's okay. You'll just have to pick up vaccine whenever you're ready to use it. So that will be more frequent pickups for you, but we can work with you on that as well. We're already planning to work with some providers along those lines. Here's what the COVID Ready portal looks like. And here's the website called covidready.com. So you might want to jot that down and visit there just so you can take a look at the applications that are required. And here is the information for the general public. So we're, at the same time that we're constructing a page for providers, we're also constructing a page for the general public just to help them get good information. And so we can push out public-facing information like, what are the benefits of getting vaccinated? What are some of the myths that you might hear and misinformation that are being promoted on social media that we really want to stamp out? So you're going to hear a lot of that if you aren't already. Even medical staff and medical professionals are succumbing to this misinformation. I think we've kind of created a population that is very tired, very alarmed, very, frankly, hysterical related to everything, about COVID, and they just can't process rational information. That's real, and that needs to be confronted. I wish I had a blanket strategy that would make everyone a smart consumer about this, but unfortunately I don't. I think we're all going to have to work together and really just rebuild that trust in science and that trust in the scientific process and in the framework that the FDA has set out with looking at the trial evidence and making sure that all the safety checks are kept in place as this vaccine plan moves forward. Just get ready for that. Get ready to have those conversations. Prepare maybe a 30-second spiel about various different questions that you might encounter, either from patients or staff, so that you can just be ready to really arm yourself with good information and hopefully help us combat the bad information that's out there. And we will help you by creating these messages and also talking points that will hopefully help you be an ambassador for the science behind vaccination. Here's more vaccine education opportunities. Some of these are recorded webinars that the CDC has done. CDPH also has some. At this point, there's just a torrent of information coming out about the Pfizer product and the Moderna product. So I'll try to, over this holiday weekend, I'll try to cull some of the better sources of information, and hopefully by next week be able to share it with you. But some of these COCA calls and the CDC sites are really good for just sharing information. And if you have any specific questions, let us know. In the last week, I think we've fielded questions related to the Pfizer vaccine more than the Moderna vaccine, although we do have the Moderna vaccine in our freezer now, and we are planning to allocate that as well. With the Pfizer vaccine, as you know, there's the vial has 5 doses that are supposed to be used, but if it's reconstituted with extra saline, then you can actually create a 6th or even a 7th dose out of that vial, which would really stretch that supply line even further. And the FDA is okay with doing that. So that's one question that we fielded, and we feel comfortable with allowing people to do that. What you can't do is to pool the little liquid residue from a bunch of different vials, because they're not multi-use vials. So you can't just pool a lot of little drops from each vial in order to create a whole new dose. But if you have a whole dose left over after the 5 doses are used at the bottom of your Pfizer vial, then you can go ahead and use that as a 6th dose or even a 7th dose. The other big question that everyone has is about allergic reactions. And although the science on this is still evolving, the CDC actually has a language on their clinical considerations page that people with allergic reactions can still go ahead and get the vaccine. They just need to be watched for 30 minutes instead of 15 minutes. And you really want to counsel them about the risk versus benefits. But I've already encountered clinical staff in my own ER who have a food allergy or a medication allergy. They may be told that they don't qualify for the vaccine. And obviously that's very disheartening for people that are ready to get the vaccine. It can be incapacitating to be left out like that. So just be sensitive about those issues. Let people know that they may experience some allergic reaction. They may even have anaphylaxis, which can be treated in an emergency setting, even in a clinical setting with epinephrine and other anti-anaphylaxis medicines, and just be ready for that. If they have an EpiPen for whatever reason, then be very careful and just be ready to use the EpiPen after they get this vaccine. But even that should not be a contraindication. The CDC says that it's a precaution, not a contraindication whenever somebody has a vaccine allergy. And if they don't have an EpiPen, if they have a mild allergy to whatever, then they're probably fine to get this vaccine. You just need to watch them for 30 minutes instead of 15 minutes and then document very carefully that they don't have any evidence of allergic reaction. And I haven't heard about any local allergic reactions. I don't know if anybody has any stories to share if you're working in a vaccine clinic already about this, but I haven't heard about any local allergic reactions from the few thousand vaccines that have already been distributed and given to people here locally. So in terms of vaccine providers, again, we're trying to work with as many people and as many settings as possible. We're hoping you can reach out to us. One thing that I did forget with the vaccine websites that I shared is we're also setting up an email for people to just email our team about vaccine enrollment. So what I'll do is when I send out this slide set, I'll include that email address. Off the top of my head, I don't remember it, but I know that Joe Prado has created one and that our vaccine program is going to be using that email as just a general inbox for whatever requests you have, whether it's, I need to get signed up, I need more vaccines, I'm having a problem that I need help troubleshooting, we will set up a vaccine email so that you can reach us, and someone from our team will be answering that as quickly as possible. I'll skip that in the interest of time. So if there's no other vaccine questions, then I'll move on to surge and crisis protocols. But if you do have vaccine questions, put them in the chat, and hopefully we'll have time left over to discuss those issues. So in terms of surge protocols, we have set up several alternative care sites that are kind of beyond the footprints of the hospitals and even their surge areas. The first one is the Porterville site. That's been activated. Their inclusion-exclusion criteria is on this next page. And basically, you know, if they have active or recent admission criteria, age greater than 18, O2 sats of greater than 92, they can get some supplemental oxygen, but no more than 6 liters per minute, and then stable vital signs. They do need to be communicative and ambulatory with just very minimal support, and labs and medications need to be minimal. So labs limited to once daily routine labs, stable comorbidities, simple wound care, and dialysis must be prearranged with a facility in Porterville. They can have Foley's, they can get tube feeding, and if they need a PT/OT, then they're okay with doing that. Exclusion criteria are also important to keep in mind, and those include if they need telemetry, CPAP or BiPAP, if they need anything more than 6 liters of oxygen, if they have ostomies, drains, or tracheostomies of any kind, pregnancy beyond 16 weeks, if they're anemic and need blood transfusions, if they are, if they require just high maintenance just because of dementia, delirium, etc., if they have any communicable diseases, or if they are unconfirmed COVID-19, then they are not eligible for the Porterville site. So we are trying. I mean, I know the hospitals are trying to send patients out to Porterville, even though there's a long list of exclusion criteria. Please continue to work with this program because it's still a good way to decant some patients. And Porterville, you know, even though they're currently active for 10 patients, I think as they get more staffing and resources, they can actually balloon up to 120 patients at that site. So we're just hoping that we can kind of refine these inclusion-exclusion criteria, and at the same time identify staff that can work out there, and hopefully that will help really get that off the ground. With the Fresno Convention Center, right now the team that's going to be working that is actually on the CRMC campus at the North Medical Plaza, and they're actually seeing patients there. I was able to visit there yesterday and several times last week, and they're a great team. They're staffed by a company called AMI, and they're really helping out a lot. There's approximately 10 patients there as of yesterday. I think that number, they are expecting to increase that number. There's technically 50 slots there, but as soon as we cross the threshold of about 40 patients there, we are planning to open up that Fresno Convention Center and just start decanting into that larger site, which has over 200 beds. So that's the plan for the stepwise progression for the in Fresno alternative care sites. At the same time, we know that we need to keep coming up with solutions for our skilled nursing facilities. I had a great conversation today with Dr. Giverts. We've had great conversations with our partners at CRMC about how we can support skilled nursing facilities. But we're open to other ideas as well. If you have any talent or interest in doing telemedicine, if you have any talent or interest in doing, for lack of a better term, emergency house calls to these skilled nursing facilities, then please reach out to us. We're just trying to troubleshoot ways to keep skilled nursing facilities staffed, not overwhelmed, and also to take care of some of the lower acuity issues that come up so that we can prevent some of those residents from skilled nursing facilities from having to go into the ER and frankly languish there for hours and hours because all of our ERs are impacted and it's really hard to find space for them. and then just coordinating the transfer back and forth is just, it's a real onerous task right now. That brings me to the crisis standards of care and the crisis guidelines. So both the California Hospital Association and CDPH are releasing guideline documents pretty much today. David Bocci, thank you very much for sharing the California Hospital Association guidelines. That's a nice checklist. I actually just included one page out of that 11-page document. And CDPH will be releasing an all facilities letter, basically aligning a lot with what our best practices and expert opinions about how to do crisis care, and really just getting everyone up to speed to feel comfortable having these conversations. Definitely hospitals, but even on the outpatient side, and some of the ambulatory procedural specialties may need to really understand what crisis care guidelines are, just so that as a community of medical providers, we're talking the same language, which is, it's a hard conversation to have amongst ourselves, and it's really hard to have with the community and with our patients, but it needs to be done because we're just in a very grim situation when it comes to capacity. And I feel like we're definitely going to have to invoke some level of crisis standards before it's all said and done. So as you'll remember, the crisis standard is actually the tail end of a continuum that goes from normal everyday things are good kind of procedures to contingency procedures and standards, which is I think where we are. I don't think that there's any argument that almost every medical facility, whether you're in a big hospital, a small hospital, out in the ambulatory care world, you're doing contingency standards. You're really making some rational decisions about how to do patient care. If people can do telemedicine instead of coming in to see you in person, then that's a type of contingency standard. You're doing that because you want to minimize the risk to yourself, to your staff, and to your patients. And that's not a normal practice, but it's something that all of us are now doing. So that's like an example of a contingency standard, is when you change your practice, but you're still delivering the same level of care. Whenever you go into crisis standards, then basically the level of care can actually change and get lowered just because there's just no space or other resources that can be released. I had a whole list of things that crisis standards could mean, but let me just share with you what the Hospital Association has come up with, because I think this is a pretty good checklist. And then I'll talk about some of the other things that I think about whenever I think about crisis standards. So again, this is from the California Hospital Association, and basically this is what they're asking hospitals to do. And I'm sharing this just because I know a lot of the providers here work at hospitals, or you may be sending your patients into a hospital setting if they get sicker. And I think it's important, like I said, for all of us to be talking the same language, just to set patient expectations, to say, look, we're in a really bad spot right now. The standard of care may be a little bit different during this time because we're undergoing these crisis standards. And every hospital has committees that are already standing up and having these conversations. And they're at different places just in terms of what their acute needs are. But I think this is a good checklist for people to go through. So obviously, review available resources and determine potential strategies. The state put out a packet in June, and when the state AFL comes out later today, hopefully, I'm sure they will point to that June packet, which is a 40-page packet, and have just a lot of information about how to do, surge planning and surge capacity planning from conventional to crisis care. Review the hospital's capabilities in managing surge and critical care. Review the infectious disease protocols, isolation protocols, just-in-time training, and pediatrics. Involving multiple disciplines in this review is very important, including representatives and leaders from nursing, administration, emergency management, emergency services, and ancillary and support services. Determining the number of pandemic patients to plan for, taking into account the hospital's role in the community and the presence and absence of other healthcare facilities in this area. Clearly something that we do all the time, but it bears repeating. we really don't have a great idea of how many patients to plan for. We're approximating that about 10% of COVID positive patients will require at least one ED visit. Um, so just keep that in mind, that whenever you see, oh, we've added 900 new cases, so you can basically just say, well, that just means 90 of those people will need to be at least seen in an emergency department, and a handful of those people will go on to need admission. That's how I kind of look at the numbers. So every time the numbers get updated, I just think to myself, okay, 10% of those people will end up coming to a local emergency department. And obviously that just makes my heart sink because these numbers are so high day after day. Incorporate indicators and triggers for surge capacity into the hospital's emergency operations plan, including notification to supervisors and partner agencies, and when possible, delegate authority to activate the disaster plan to the emergency department staff or nursing supervisors in charge. So these are the kinds of things that the hospitals are actively, I think, discussing. We're trying to support them and just give them ideas and resources as needed. And on the pre-hospital side, I know Dan is listening in. He's been just working tirelessly to make sure that we're really not caught flat-footed when it comes to our EMS operations. We're already making some changes to make sure that we are protecting the EMS system as well as protecting the hospitals in terms of who gets transported. If they at all can wait to go to their primary care doctor or go to an urgent care center as opposed to an emergency department, we're already invoking those protocols. And we want to deepen some of the alternatives that we can provide with things like telemedicine and even community paramedicine that we're trying to stand up very quickly. So again, people are working on emergency operations planning. I think that the real challenge becomes really the concept of this continuum as opposed to a switch. Because when you flip a switch, you flip it and then it's done. You're kind of through that threshold and there's no going back. But when you have a continuum, which is what's necessary here, some days you may have a resource such as space in your emergency department, and some days you may not, and that space is gone. And so that's kind of the ebb and flow that we've been experiencing, just working clinically in the emergency department, that the ICUs are experiencing. For the most part, the ICUs are totally stacked up. But beds do come and go. Patient traffic comes and goes. Some days are busier than others. And so it's really, frankly, fatiguing to have to respond to those realities on an hour by hour and day by day basis. But that's just what our leadership is having to do. And we just need to all be, I think, just train these muscles so that we can do this better and better, especially in the weeks to come when we know that this surge is not going to let up for the next few weeks. And depending on how Christmas goes, it may just generally get worse if people decide to have a lot of gatherings and the rates of transmission go up just related to Christmas holiday. Educating and training staff. Again, I'll include a link to the whole packet so you can read through it. But basically just, making sure that our staff are prepared and supported through education. And I would say just, just awareness of how fatigue can impact people's decision-making and productivity. I mean, I've talked to you about mental fatigue and mental wellness before, and I really think that this is a productivity issue in addition to just being a kind of a humanitarian issue. Is when people get tired, there's always that room that, more and more errors will accumulate. And I think we need to be sensitive to that. And really, staff fatigue and staff morale and staff productivity are completely intertwined. And we just need to really help protect and support our staff during these really hard days as best as we can. Okay, so that's just a very quick overview of crisis protocols. If you're not having those conversations and you want to be part of them, let us know. Most of you who are in these positions are already having these conversations, and that's great. We will continue to have these conversations and share resources as best as we can. Just going back to surge protocols one more time, the question came up is there a declaration that's required? Some states, not California, actually declare that they're in crisis mode, and they declare that they're moving into standards of crisis care that are different than standards of care on a normal day. Well, legally, that doesn't need to be done. We asked the state, and the state is really assuring everyone that from a medical legal standpoint, you don't need to do a declaration, but you just need to have good internal communication and really just a committee that makes these decisions ahead of time so that these kind of allocation and rationing decisions aren't done on a patient by patient basis and really shouldn't even be done by the bedside providers in some cases, just to kind of create a layer that's a little bit more objective and algorithmic about things like, one example is ventilator allocation. We're really not short on ventilators, but you can imagine that that would be a really hard decision for the individual physician at the bedside to make. And so there's committees that are created that really take a look at objective criteria and then allocate ventilators that way. So we're not there yet, but these committees do need to start meeting and talking, just because I feel like we may well be there, if not with ventilators, then with other supplies, and we need to just be fully prepared and use all of the tools that we have in our toolbox, so that we can make good decisions when the time comes. Okay, let me speak briefly about monoclonal antibody infusions. So again, this is a checklist for the bamlanivimab. The other antibody product is also available. It's allocated to our county, and it has similar inclusion criteria. Basically, if your patient has had COVID for less than 10 days, really the earlier the better, and they have a high risk criteria, such as obesity, kidney disease, diabetes, immunosuppression, age greater than 65, cardiovascular disease or respiratory disease, then they may qualify for these monoclonal antibodies. We've run into some roadblocks about getting them infused, but we've also had some people kind of come out and say that they want to help us, which is so great. So we've had great conversations with area compounding pharmacies that are ready to help mix these medications, and we're reaching out to skilled nursing facilities to make sure that they know that these medications are available so that they can start infusing them. In terms of the infusion, that takes about an hour. And after the infusion is done, it really takes about another hour of observation to make sure that you don't have infusion reactions to the antibodies. In the same way that antibiotics can create allergic reactions, these antibodies can also create allergic reactions. And they're really something that can be managed on site. They would not necessarily need a transport to the emergency department as long as you had good infusion reaction protocols in place. So we really feel like we're going to be able to support skilled nursing facilities as well as any infusion center, emergency department, or even primary care clinic that wants to do this. Again, if you're seeing COVID patients that have high risk factors, the number needed to treat is about 30, which means that you can really save someone a hospitalization or an ICU stay if you do just a few dozen of these infusions. And just to give you a ballpark figure, we're getting doses. We're getting approximately 200 doses every week, and we're not even using those doses. So I really feel a lot of impatience that we need to be using up all of these doses, because I feel like, if we can at least save even 5 admissions or 5 ICU admissions with those 200 doses, that would be worth it, in my opinion. And it may be more, just depending on how the patients are selected. We're learning more about these infusions as time goes on. So I really feel like it's worth investing in this program, and I hope that I can hear from some of you if you're interested in helping out. Again, we just need some space, some nursing personnel, some medical direction. I feel like we have the pharmacy piece in place, and we'd love to dialogue with you about getting this done. And for those of you who have reached out to us, like Dr. Bautista, thank you so much. We really look forward to working together and making sure that this works for everyone in a way that's safe and efficient and streamlined. So please reach out. I think that's about it. My last slide is just the best advice for Christmas is stay home. And just to refer my 2 favorite Christmas movies, stay home alone so you don't die hard. Tell your patients, tell your staff, tell your neighbors, tell everyone we need everyone to just stay home this year, celebrate Christmas remotely, and get through this surge as quickly as possible. The vaccines are here. It's a light at the end of the tunnel. We just want to be able to get everyone out of the tunnel safely. So please continue to do all of the hard work that you're doing, but also take time to rest and recharge. Enjoy Christmas with your families if you can, and otherwise have a great weekend. And we will see you in 1 week on the same day, Wednesday at 2 p.m. Thank you so much. Okay, I think we have some chat questions, so I will go to the chat and see what we can do there. Let's see where we're at. Oh, here we go. Okay, do oncology practices fall into tier 1? Yeah, I believe they would. I think any kind of patient-facing, if you're a frontline provider, you will fall. The phases and the tiers are different. So phase 1 would cover clinical practices. Whether you're actually in phase 1A or 1B, I'm not sure. And then beyond phase 1A and 1B, then they have the tiers, which the state made up. So we will work through that. The best thing you can do is email us. Like I said, whenever I send out these slides, I will actually have the COVID email. But in the meantime, you can email Sim or myself, and we will get you in touch with our COVID vaccine team, and we will get you good information about where exactly which allocation tier your practice is falling into, and hopefully that will clarify a lot of the questions you have. Will the ACS facilities be able to accept higher acuity patients? We have COVID, less than 10 to 14 days who are pending SNF patients placement that cannot be transitioned to ACS due to requiring, I don't know what that means, greater than minimum ambulation. Yeah, good question. I would say work with the ACS phone number that's been set up to talk through whether they're ready to accept your patient. If you're really running into roadblocks or not having a good conversation, then get us involved. But the transfer center phone number is 600-7807. So hopefully they'll give you good information about yes or no, and if the answer is no, then why not? And hopefully that will give you some direction to move in, Pamela. Can we get a list of who we can refer for infusions? Yeah. So I'm assuming that you are wanting a checklist of the inclusion/exclusion criteria and also a list of clinics that will take your patient to do infusions on them. So yeah, certainly we can try to put those things together. So we'll create a packet for you to get you information that you need about infusions. Was most of the Moderna shipment viable? So I'm not sure where that landed. I know that some of it had to be sent back, or some of it is going to be replaced, just because the cold chain could not be documented whenever they ship that box to us. And so every one of these boxes, whenever you open the box, it actually has like a thermometer digital logger. And that basically keeps a record of just how cold that box has been. And if the temperature is just way out of range, then basically it fails. It fails. And so we have to call the state, and then the state says, okay, fine, we'll send you a new shipment. So obviously that was disappointing, but they're still working out the kinks on that. And we were told that we were going to be getting a replacement of all of the Moderna doses that we were not able to use. So that's what I know about that. How soon can we start to refer patients for infusions? What offices are currently accepting referrals? Okay, great question. We will try to get information on that. We're talking to a couple of different offices what I'll do is right after this call, I'll just confirm that it's okay to list their names and numbers on my slide set. And if they're okay with that, then I'll just put it on my slide set and we'll send it out later this evening. And hopefully that way that you'll have at least some actionable places to refer people. Again, I sense your impatience and I feel your impatience. And I wish that we had, a stronger pipeline for getting these antibodies into patients. We're just really struggling with trying to get all of the pieces in place to get these antibodies into the patients. Do I have an anticipated timeline for front-facing health providers outside of the bigger systems to be able to access vaccines? I really don't. I mean, we're working as fast as we can, and I'm sensing that hopefully in January, definitely by the first week or two of January, we'll have a really good timeline, and hopefully we will be able to cover as many of you as possible who are ready to get vaccines. Again, I don't want to make any promises just because there's so many moving pieces to this, but we feel really good that we've got a great team in place. Sim just shared the email, the COVID enrollment at fresnocountyca.gov. So you can send an email to that email address. If you want, you can CC me and Sim on that. I'm just Vohra at fresnocountyca.gov, and Sim is on here also, so that we can make sure that we really get you pointed in the right direction. And like I said, when this website goes live, then you'll be able to see exactly what the process is to get yourself prepared to apply for being a vaccine provider. Any other questions? All right. Well, I will work on this slide set and I'll get it out this afternoon. And I really just want to say thank you for all of the hard work that you're all doing, and appreciate the feedback. I know that there's a lot of anticipation and concern about how these vaccines are going to get rolled out. I assure you, we're going to do our utmost to make sure that we get everyone vaccinated as soon as we can. So we really appreciate your partnership and your patience as we try to work through our processes. Again, hopefully the website will give you things to read, things to apply for in the meantime, and really ways that you can start educating your staff and your patients. I mean, it's really going to be a tall order to get everyone vaccinated who needs to be vaccinated, and we all need to partner to try to get the message out to everyone. What is your New Year's resolution? Asks David Lucchini. I don't know. I have to think about that. Conquer COVID. Winter soccer match, says Rick Lembo. Yeah, that's a good one. We'll have maybe that'll be your homework, is come up with a good New Year's resolution, and we'll talk about it next time. All right. Oh, good question just came up. Sorry, just at the last minute before we're about to say goodbye. Can Porterville ACS administer remdesivir for a low acuity patient? That's a good question. I'm not sure if they're able to. From what I understand, they have to be convalescent. So I'm leaning towards no. I think that they probably want you to wait the 5 days to go ahead and administer remdesivir at your site, and then send that person over. So I think that that's kind of how they would answer. But again, I don't want to answer for them. So that's another good question just to ask that the phone number that I shared earlier. But they really want convalescent, meaning people that are cleared from the COVID based on isolation criteria, or people that have finished their remdesivir dosing at least before they'll take people. Is it still recommended to take the day off after the second shot of the Moderna vaccine? So, you know, it's interesting. I got my vaccine last week, and I really expected to feel terrible the next day, and I felt fine. And that's what most people are saying. Is, you know, certainly after the first shot, most people are just, they may be a little sore right where they got the injection, but beyond that, they're feeling fine. The second shot, because your immune system has been primed a little bit, may actually create more of an immune reaction. And that's where, you know, the second shot may actually make people feel sicker, as it were, with that immune, it's called reactogenicity, but basically that your immune system is fired up and ready to go. And that's good. That means that the vaccine's effective in making your immune system really fight the molecules that it needs to fight. I think only time will tell whether people really need to take the day off or not. You know, the CDC says for really unbearable or really severe post-vaccination reactions that you have to, or that you are okay to give NSAIDs or Tylenol. And so, you know, there may be some people that just can pop a Motrin or a naproxen and then go to work, whereas other people will just feel so low on energy and will feel so kind of incapacitated that they may need to take the day off. It's hard for me to predict. I would say that would be the ideal, is to have people take the day off. But if they can't do that, then they may need to, you know, take it easy, take some NSAIDs, et cetera, in order to get through that, the second day after the second shot. Will the county need a head count of how many of our employees plan to receive vaccine when it becomes available? Yes. So that's I think that's one of the things that you'll have to submit for your vaccine distribution plan. And again, you know, it's part of the application. Certainly, it's something that the hospitals had to submit. So I would be surprised if you didn't have to submit that information for the outpatient providers as well. So definitely you know, get a sense of how many of your staff and providers want the vaccine. It's probably around 30% are ready to get it now, but it may be more, it may be less. But that certainly helps our planning also, is to get, you know, if you can get people to commit to accepting the vaccine now, then that will help our planning process, and that will just make the rollout that much more efficient. And I know that our skilled nursing facilities are partnering with CVS and Walgreens as early as next week. So that's a great development also, is that very vulnerable population and the staff will be able to get their vaccines starting next week. All right. Any other questions? All right. Well, have a great Christmas holiday. Merry Christmas, and we'll see you next week. Thank you, everyone. Take care.
Thank you.